The broadcast is now starting. All attendees are in listen-only mode.
Good morning, and thank you for joining us today for the Ohio Healthy Homes Network webinar series. Our talk today is Why Healthy Begins at Home. I'm Katie Fallon, the Director of Housing Policy at the Ohio Housing Finance Agency, and I will be moderating our session. OHHN's work centers around the idea that having a safe and affordable home is foundational to all aspects of life, but especially health. And we have been lucky enough to work with the Healthy Beginnings at Home team for the last 3 years on their program focused on addressing infant mortality in Central Ohio through the provision of stable housing and services. I'm excited to hear from our panelists today as they discuss the role of housing in infant and maternal health and what they have learned through their work. Some housekeeping items before we begin today. First, I'd like to thank the sponsors of this webinar series and all of COHIO's staff for their assistance with making this webinar series possible. For participants, you will be on mute. If you have any questions or comments throughout the webinar that you would like addressed, please use the chat box on your right to ask questions. We will collect the questions and direct them to the speakers during the Q&A sections throughout this talk. Participants can also use the chat box to let us know if you're having any difficulties or to ask for help. All Ohio registered sanitarians applying for CEs should enter their name and RS number in the chat box at the beginning of the webinar, and also again at the end of the webinar. A survey will immediately pop up at the end of the webinar. Please participate in that survey to provide valuable feedback to us on the session. Any registered sanitarians will need to re-enter their information at that time as well. And finally, this webinar is being recorded and will be sent after the webinar ends. The session will be posted at www.ohhn.org in the calendar section. So before I introduce our participants, we're going to start with a poll to give us a sense of who is in the audience today. So there's a question that's going to pop up and you just answer it on your screen, with the question being, are you working on making connections between health and housing affordability in your work? We'll wait a minute to give you guys a chance to answer. Give everybody another few seconds, and then I'll have Parker pull up the results. All right, so it looks like we have a very housing-focused set of attendees today, but about 19% so almost a fifth, focused on the affordability of housing and health as an intersecting point. So this is good to know as we move into the sessions, and I will introduce our participants today in order of their presentations. So first off, Barbara Poppy is the founder of Barbara Poppy and Associates. She served as the executive director of the U.S. Interagency Council on Homelessness from 2009 to 2014, during which she oversaw the federal response to homelessness and helped create the nation's first ever comprehensive federal plan to prevent and end homelessness. Ms. Poppy has more than 25 years of experience working on homelessness with housing-related nonprofit organizations such as the Community Shelter Board in Columbus. She serves on the National Board of the Enterprise Community Partners and the National Advisory Board for the Center for Evidence-Based Solutions to Homelessness. Next, we have Priyam Chokshi. She is the Director of Community and Legislative Strategies for Celebrate One, an initiative in the Mayor's Office to reduce the infant mortality rate and improve health equity in Columbus. Previously, she served as a policy advisor to Mayor Ginther, where she worked to create Kiva Columbus and the Columbus Women's Commission. Priyam graduated from the George Washington University with a degree in International Affairs and is working towards a graduate degree at Harvard University currently. And Amy Regal is the Director of Housing at CareSource, where she is focused on creating innovative and sustainable approaches to integrating health and housing. Previously, she was the Director of Jobs Connect Ohio at CareSource, leading the effort to assist Medicaid members in removing barriers to high-quality employment. Prior to joining CareSource, she was City of Dayton for 10 years, serving as the Manager of Community Development and Grant Administration. She has served on numerous boards within Ohio and nationally that are focused on poverty elimination, affordable housing, and neighborhood revitalization. I will turn it over to Ms. Poppy to begin the presentations.
Good morning. It's great to be here with you all to talk about our work in Columbus. And today we're going to talk about healthy moms and babies, housing and health integration. Next slide. We're going to start out with first talking a little bit about why we're tackling housing affordability as we try to improve maternal, birth, and child outcomes. We'll then shift into a discussion about the actual project that we undertook. And with an overview, some preliminary research findings. We're partway through our study, and then we've concluded the process evaluation and have some really interesting things to share there. So we want to cover that with you. Then you'll have a chance to ask us some questions about the project, and then we'll shift into a conversation about the policy recommendations that we see as emerging from this work at Healthy Beginnings at Home. We want to ground our presentation in the words of the participants in our project with this quote: "I never got this much support and help before. Having your first baby, you don't know what to expect. They were here to support me and ask me about my baby and ask me if I needed transportation and all that stuff." So that is really grounded in why we came together to form Healthy Beginnings at Home. Next slide. So you might be asking, why would we think that housing affordability could improve maternal, birth, or child outcomes? Next slide. The research literature has been documenting a correlation between homelessness and prenatal and early life on their child health outcomes. So there have been a few studies that have made these correlations that show that housing instability, homelessness do have some impacts. Next slide. I want to say that one of our project members is Dr. Megan Sandel, who's based in Boston, and she has been part of the group called Children's Health Watch. And so we're presenting some of the data that she has found through her work at Children's Health Watch. And what you can see here in this slide is that prenatal homelessness, perinatal homelessness, all have impacts on key birth outcomes in terms of low birth weight, prematurity, or birth weight in the this other measure that they have, the scientific measure. And so this is really startling information, is to find out that when homelessness occurs does have some impact. Next slide. Got some graphs here, I think, that show this even better. So what you can see here is the red bars are prenatal homelessness only, the orange bar is postnatal homelessness only, and then the blue bar is homelessness both prenatal and postnatal. And you can see that all of them have health risks, but it is particularly strong when you have both prenatal and postnatal. The doctors call this a dose response. So a higher dose of homelessness results in poorer health outcomes for infants. Next slide. Parker, next slide. And back one. Parker, can you, there we go. The other piece that we know is that long durations of homelessness also affect child health. So these are two really important things, is the timing of when homelessness occurs and the length of homelessness really have negative impacts on children. Next slide. So Dr. Sandville is underway with this really interesting study that is for medically complex families, and they're doing a pilot which, like Healthy Beginnings at Home, is a randomized trial. And what you can see here is there are differences between the intervention group and the control group. So the intervention group that receives housing does significantly better improvements in child health status and parent anxiety and depression score. So really important findings as well. And next slide. So in Ohio, the reason we decided to undertake this effort is because there has been this really significant increase in homelessness amongst infants since 2017. So think about this, since a 53% increase over 5 years in the number of infants who experience homelessness. So our belief is this probably does have some impacts on the infant mortality rates across the country, or across Ohio. Next slide. And we know that there are racial disparities. While Black Ohioans are only 13% of our state's general population, they make up as much as 50% of the homeless population. So Black Ohioans are much more likely to experience homelessness, which also correlates with Black mothers are more likely to have poor maternal and birth outcomes, as well as experience infant mortality. The infant mortality rate is significantly higher for Black infants. Next slide. So our project is located in Franklin County. Franklin County, as you know, is a growing urban county in Ohio that is experiencing rising rental costs, rising rental burdens, and high rates of family homelessness, which correlates also with child homelessness. It also has a very high infant mortality rate, which our community has been tackling under the auspices and leadership of the City of Columbus, Mayor Ginther, and the Celebrate One. And so our project is based in this community. Next slide. And so what you can see from here is that in order to afford a 2-bedroom apartment in Franklin County, Ohio, you need to work full-time and earn over $19 an hour. However, most of the jobs that are available in our community with openings are in fact paying much less than that. So working members of our community who are working as nursing assistants are still making under $14 an hour, which puts them at a significant gap. The gap is also exacerbated because often these are positions that are not full-time, regular hours. And then further compounding that is when you are pregnant, you have a hard time maintaining steady employment due to the challenges of being pregnant and often job discrimination as well. So it's very challenging for pregnant women to have sufficient incomes to afford a quality apartment in our community. Next slide. And the housing cost burdens are even more extreme when we look at the racial groups. And you can see that Black households are 52% are likely to have a housing cost burden, paying more than 30% of their income for rent, an even higher percent. And additionally, within that are households who are paying more than half of their income for rent, which puts them at a severely cost burden status. What this means is there's a really strong stress on families trying to make it. Many of the households, this only reflects households who actually have an apartment. This does not reflect the households, the many family households and pregnant women who are staying with family or friends, living in doubled up, overcrowded, unsafe conditions really in many situations. So we have a severe affordable housing shortage in Columbus and Franklin County. Next slide. So as I move this over to Priam, I just want to say what we saw is a lot of correlations across the research between these connections. And so in Healthy Beginnings at Home, we tried to make the connection between providing rental assistance and housing stability to see if that would improve the outcome. So we're really excited about the work we've done so far, but I'm going to pass it off to Priam to talk more about our local study.
Thank you, Barb. You have really set the stage to why an initiative like Healthy Beings at Home is needed in our community. Next slide. So Healthy Beginnings at Home is truly a community collaborative and one that involves many Celebrate One partners. Celebrate One is a coalition of partners committed to improve the infant mortality rate in Columbus and Franklin County. In June 2014, the Greater Columbus Infant Mortality Task Force ended its 6-month process with the release of its final report to the residents of Franklin County. In it were 8 recommendations to reduce the community's alarming infant mortality rate by 40% and cut the racial disparity gap in half by the end of this year, 2020. So Celebrate One was created in November 2014 to carry out the task force recommendations and ensure that Franklin County meets its ambitious goal. We are a collective impact initiative made up of a vast coalition of multi-sector partners working to reduce preterm births, eliminate sleep-related infant deaths, and improve the socioeconomic conditions that drive disparities in our highest risk neighborhoods. So safe and stable housing is widely regarded as a key social determinant of health impacting pregnancy outcomes. Research findings show that housing instability or a shelter stay during pregnancy increases a woman's risk of having a premature birth by 200%. In Franklin County, Ohio, prematurity is the leading cause of infant mortality. For Black infants, the numbers are devastatingly high. In comparison to white infants, Black infants are significantly more likely to be born preterm and 3 times more likely to die before their first birthday. Housing instability and homelessness may play critical roles in these persistent perinatal health inequities. Given the significant impact of safe, stable, and affordable housing on maternal and child health, rental assistance programs for qualifying pregnant women can improve birth outcomes. Next slide. And we'll go to the next slide. Thank you. Here you'll see how the study and work is funded, primarily with the support of the Ohio Housing Finance Agency. We've been successful in securing multiple private donations for the work, almost doubling the initial investment. Next slide. So Healthy Beings at Home is a public-private partnership, and its efficacy is due to the many partners you see listed here. Healthy Beings at Home brings together direct service and expertise from a diverse set of organizations, including the Columbus Metropolitan Housing Authority, the Homeless Families Foundation, CareSource, Step One, and Children's Health Watch. Researchers are using a randomized control trial to assess the impact of Healthy Beginnings at Home. A research team from Nationwide Children's Hospital is evaluating the program's health outcomes, and researchers from the University of Delaware are conducting a housing outcome evaluation. So now I would like to hand it over to Amy Riegel to discuss the details of the study and early learnings from the research. Thank you.
Thanks, Priam. It is an honor to be here today and so glad to be a part of this initiative. Next slide, please. So as we move, especially through the last 7 months, as we've gone through the pandemic, everyone realizes just how important a place to call home is, and also within our homes, how much space means to us. And so this is just another quote from one of our participants, really talking about what it means for a child to have their own bedroom, or that safe space that they can have as their own, and also allowing for the parent to have a room of their own and to have their own space for mental and physical health to be achieved. And so that is such an important part of the work that we're doing here. Next slide. Barb and Priyam have both talked a little bit about the study. Just to emphasize that one of the main elements of this study that really should be underscored is that there is a lot of research out there about the impacts of not having affordable safe housing on health, but there are very few studies on what are the health outcomes when you do have safe, affordable housing. And so Healthy Beginnings at Home really starts to build on that level of research, showing that there is a direct connection between the provision of safe and affordable housing and better health outcomes. And so as the state of Ohio sought to look at how to reduce infant mortality, they did look at a very holistic approach, not just saying, hey, Department of Health, can you please address this? Or, hey, ODM, can you please address this? But really looking across the board at all the sectors that were possibly interacting with infant mortality and saying, hey, what is your part you can do? And OHHN, the Ohio Housing Finance Agency, was a great lead at taking some of the funding that was put forth by the General Assembly and saying, let's put this out here and see the connection between health and housing. And the Ohio Housing Finance Agency has been an amazing partner in this work. And Katie, we appreciate all the leadership and guidance that OHHN has provided throughout this process. What we see now is that through this research study that there are additional state, local, and federal policy implications that we're going to be able to glean from this work and take on in the future. So this study, 100 women, all of them were CareSource members, which becomes important later as we talk about findings and how we're able to dig into more granular level of the health outcomes. All of them were pregnant in the first or second trimester. They lived in Franklin County, under 30% of the area median income. Most of them were actually below 15% of area median income. And all of them were either housing unstable or homeless at the time that they entered. And what we really looked at was that everything else would remain usual care, but that the intervention group would receive a rental subsidy that was time limited and that was supported by housing support specialists. Next slide, please. Definitions are incredibly important, especially when you're talking cross-sector between health and housing. So defining what housing unstable meant was very important. And so these were the elements that we used to define housing unstable. We did also enter women into the program who were literally homeless, either most of them were living in shelter at the time. But these were the elements. Oftentimes this can become more broad as you talk to different sectors, but we kind of took a little bit of the more high risk approach from a housing definition. Next slide, please. And as we looked at the rental assistance, the women did receive rental assistance for 15 months, only paying 30% of their income. The average payment during this period of time was $27 a month for the participants. And then there was a step down period. There had been a micro pilot previous to Healthy Beginnings at Home that was conducted with Community Development for All People. And one thing that was identified in that micro pilot was that this step down period was incredibly important. Earlier, Barb talked about what the housing wage is in the state of Ohio. But when you think about a pregnant woman after this program, she would have a small child within her home, at least one. And so she's looking to work not only to pay to earn a housing wage, but also having to pay for child care. And when we add on child care, we see that women have to actually earn about $26 an hour in order to earn enough to pay for their rent and for adequate child care. So we do see that it's very important that the women have subsidy and a step down plan after the intervention. So that was all very intentional from the very beginning. Some of the women, over half of the women in the intervention group, were able to secure housing that had an ongoing subsidy through mainly through Columbus Metropolitan Housing Authority. And so that has been a great element that some were able to secure that from the very beginning. Other women have been able to either be on the wait list or become eligible for subsidized housing either before the program ends, or they kind of have a head start as the program ends into receiving their voucher or placement in housing. Next slide, please. And this is just an example of what it looked like for the women as they stepped down in their rental payment. As I said, it did pay their rent except for women contributing 30% of their income for the first 15 months. So that took most of the women through their pregnancy until the baby was usually about 6, 7, 8 months old. So it did give them the time that they were pregnant plus a postpartum period, and getting them a little bit closer to where the child might be eligible. There may be more seats open in childcare. Some of this did change as COVID impacted, childcare and work for the women. But as the study was designed, this was our intention. They then stepped down over the course of 5 months, and even though in the last 3 months they're paying the full rent, they still have the housing support specialists who are there to help them, whether it's renegotiate the lease or figure out payment plans, figure out utilities, whatever it is, they still have support there to help them with these. Next slide, please. And as we think about that housing support specialist, I think that there is no way to there's no way to emphasize enough how important this role was in the study. And so they helped to enroll the women in the program. They helped to assess their needs from the very beginning. They helped to negotiate the lease and to find that first unit that the women moved into. They helped the women understand tenant-landlord relations as they lived in the units, in some cases, how to deal with maybe a neighbor or someone else in the unit or in the complex that they may have friction with, and even how to address environmental issues within the unit or within the neighborhood around them that they may see that was impacting their health or their child's health. Then renegotiating the lease became extremely important as the 1-year mark came. So this role was incredibly important, and I think that within community, really emphasizing the need for specialized talent in this space is critical. So as we think about replication, this is really an area that we can't just assume is already out there, but the capacity building, training, support kind of to help agencies be able to fill this role. The women also received usual care. And so whether they were in the intervention group or the control group, they were receiving clinical case management. They were could be receiving services from a community health worker. Maybe they signed up for the home visiting program, life coaching or workforce development, educational support, any of the supports from like a Moms to Be program. All of that is incredibly important also, but it was offered to all the women. We did see that between the two groups that there were very similar outcomes when it came to, especially from our perspective, from clinical outcomes. both positive, how many times did they go to their prenatal appointments, were they taking their vitamins, were they following doctor's orders. We saw that both sets of women were very compliant in following through with that prenatal treatment. We also saw some similarities in negative behaviors, such as difficulty with smoking cessation, or rates of gestational diabetes, or other types of illicit drug use during the pregnancy. So we saw positive behaviors that were very compliant, yet at the same time, we still saw some behaviors that could have been modified, but that exist that many pregnancies see. So next slide, please. And so with usual care, there were no changes in the benefits that the women received for health care. There was no difference in their network of doctors or hospitals that they could attend. They also, if the women were in the control group, they still received usual care housing support. So they could still seek services through the Community Shelter Board, or they could still seek services through Columbus Metropolitan Housing Authority. The difference just was that they weren't given this rental assistance and housing support specialist. Next slide. So the next part is what we're learning from the research and evaluation. As Barb said, this program is not complete yet, and so there's still a lot to be learned. What we're going to talk today about are just preliminary findings, and so these could change. Hopefully, as we learn more, we'll have more to say about each of these issues, but this is what we've seen so far. Nationwide Children's Hospital will be doing the final analysis come December, and should be wrapping up in early spring, late winter of 2021. And the question that we really looked at was, can the provision of safe and affordable housing during pregnancy improve health outcomes for birth, maternal, and infant, and can it reduce infant mortality? And so once again, this was not the question of if you don't have safe and affordable housing, do bad things happen, but rather that reverse question of if you do have safe and affordable housing, do positive things happen? Next slide, please. So Nationwide Children's Hospital has been the lead researcher in this effort. They have conducted surveys with both the intervention and the control group throughout the entire process, and they've asked many questions about the women's perception of their situation, in addition to questions about their current circumstances. And along with the information that we're collecting from the women through the surveys, we also have clinical data that's being provided by CareSource. This is where it became valuable that they were all CareSource members. We've been able to pool their claims data and other information that we receive as the payer of health insurance about the women's health status and their health outcomes. So all of that is being layered together in order to do this analysis. Next slide, please. As mentioned earlier, so we did find that although none of this was targeted in the enrollment of the women, we did find that 81% of the women are non-Hispanic Black, and 10% white and 9% multiracial, Hispanic, Black, or multiracial. The average age was 25.5, and so it was a fairly young demographic. 81% had a prior pregnancy. What we did find with all of the women who had a prior pregnancy, that they all reported some type of complication during a prior pregnancy. Many of them had had multiple pregnancies prior, so at least during one of them, they reported a complication of either low birth weight, preterm, stillborn, or miscarriage. even though we had 81% who had a prior pregnancy, it was only 64% of the women who actually had another child living within the home at the time they enrolled. So you can definitely see that there were many pregnancy complications that these women experienced. Next slide. And so as we look at some of the housing barriers that the women experienced, so over a third of them had a prior eviction. As we look at the data on this specific group of women, we saw that some of the women had multiple prior evictions and that there was a history of eviction even in a very short period of time. As we take this learning and start comparing it to all the pregnant women we serve who are housing unstable on our plan here in Ohio, so as CareSource looking at all of our pregnant women on our Medicaid plan here in Ohio, what we saw that this number was a bit underrepresented compared to our general population, that we see even more of our women have prior evictions, and that in some cases it's up to 24 prior evictions that we see for women of childbearing age on our Medicaid plan. So the eviction is a very important indicator that we're looking at for health stability for our women. And then criminal record, about the same, a little bit over 1/3. And then as we looked at utility debt, the women had significant utility debt, whether that be electric or gas arrearages, and that was an important piece that we had to address at the very beginning in order for women to be eligible for the program. And the women at enrollment, a certain amount could be paid off in utility arrearages for them to enroll so that they could move into a unit. And in many cases, that often wasn't even enough. We paid, I believe it was up to $1,500, if my memory is still serving me correctly. And many of the women had more than $1,500, making them ineligible for the program. So we know this is also an area that has to be addressed as we move forward. Next slide, please. And so the other part was, as I said, the goal of the program was for the women to be 30% or below AMI, area median income. And what we found is that the vast majority of the women were below 15%. Almost half of the women had zero income. And so that was definitely a factor in how we look to place the women and why so much emphasis was helping them to find subsidized housing. And then as we looked at credit score, another interesting fact that we found was that 54% of the women had no credit score. So it wasn't an issue of how do we do credit repair or credit improvement, but rather how do we help women establish credit. Next slide, please. And with the women, there were many issues of where they demonstrated that they had many previous negative housing experiences, whether that be a episode of homelessness, or they had long-term concerns on how to pay their rent, but also a common issue that was expressed throughout the entire program was just the women's desire to find safer neighborhoods for their families to live. And how could they find that and stay established in that housing when they were able to secure housing in more desirable neighborhoods. And so as we see changing demographics in neighborhoods and changing pressures, especially within Columbus, in the neighborhood designs, how do we make sure that individuals can remain in some of the neighborhoods that are transitioning and improving, and then also how can they find units in more desirable areas, especially now that they have children within the home and maybe considering education and other amenities for their kids. Next slide, please. And so as we start to talk about health outcomes, we see that there is definite differences between the intervention and the control group. Kelly is not on the panel, but if he were here, he would make me say that these are not statistically significant. We knew from the beginning that the study was not high enough power. It did not have enough people in order for us to get statistically significant results. But what we do see are trends that indicate to us that a larger powered study is valid and that it we have a strong belief that a higher powered study would help to validate what we've learned here. So one of the things from a healthcare payer perspective that we saw was not something that we initially looked for, and that was NICU utilization, so the neonatal intensive care unit within a birthing center. And so what we found was that the intervention group was 60% less likely to need NICU stay at the time of birth. And so that intervention group, they were less likely to need to even go to the NICU at the time of birth. If they did go to the NICU, what we found was that the intervention group, their length of stay was 75% shorter. It went from an average of 8-day length of stay for the intervention group to an average of 29 days. We actually had 5 outliers within the control group where their length of stays were over 40 days. And so that significantly impacted the length of stay. Part of that could have been how acute the nature of the illness of the babies, and we'll talk about prematurity and birth weight in a minute. But the other part that often impacts NICU stay is discharge planning. The hospital has to know that there's a safe environment for that baby to go home to, and that stable treatment can still be provided once the baby is at home. That's much easier to do if mom has a stable, safe, affordable house to go home to than if she's couch surfing or doubled up or in another unfavorable type of condition. So next slide, please. So when we look at the intervention group to the control group, you'll see when it comes to full-term and healthy birth weight babies, there's a significant difference. And this impacts the NICU stay also. The intervention group was just more likely to have babies that were born full-term, so that's 37 weeks or more in gestational age, and that they were a healthy birth weight, which is about, for those people who don't do math conversion like myself, it's about 5.5 pounds at birth is about the weight that they look for as healthy birth weight. Within the intervention group, there were no extremely premature babies or extreme low birth weights. In the control group, there were babies that were born extremely early and low birth weight. There were also 4 pregnancy losses in the control group, whereas there were no pregnancy losses within the intervention group. Those are just the preliminary findings. We're still learning more. We still have a lot to learn as we look at what happened to those babies in their first year of life. We've only so far looked at the data up until the time they were released from the hospital after birth. So now we'll see what happens. We also know that there's going to be great impacts from COVID on, the immunizations and the well checks and some of that normal doctor visiting kind of stuff that you do with a newborn baby. And so we will look at that and start digging into what's the impact of that strain on the women who are in the program also. I'll now turn it over to Priyam to talk about the process evaluation.
Thank you, Amy. So next slide, please. Great. So Celebrate One contracted with the Health Policy Institute of Ohio to conduct a process evaluation that serves as a companion to the health and housing outcome evaluations. While the outcome evaluations measure whether the program worked, the process evaluation provides information about why the program may or may not have worked as intended and how it can be improved. So the intended audience for this report includes any state or local organizations that are considering replicating or scaling up Healthy Beings at Home model, or are planning similar projects to improve maternal and child health outcomes by improving housing quality and stability. So HPIO employed the following process evaluation methods. They did a document review, observation of core team and care coordination meetings, and analysis of meeting minutes. There were key informant interviews with 8 Healthy Beings at Home participants and key informant interviews with 15 staff and partner organization representatives. Next slide, please. So some of our key findings you'll see here, I think are really telling. You know, cross-sector partnership is challenging, but it's worth it. You have this very healthy tension of health and housing partners, ultimately trying to improve birth and housing outcomes for the population that reside here in Columbus. You know, housing stability specialists, they're critical components of the program that Amy spoke about earlier. Racism, trauma, and violence must be addressed. I mean, this is, as Amy kind of outlined the demographics earlier, most of our Healthy Beginning at Home participants were Black. We know that historical and contemporary racist housing policies, residential segregation, and neighborhood divestment all serve as significant external barriers to housing stability and positive health outcomes. She also spoke about some of the challenges with COVID-19 pandemic and how that threatened a little bit of our process. And then ultimately, we really learned, and you'll see the quotes throughout the presentation from our participants, that the participants were incredibly resilient, you know, in all of the issues they were facing, and really formed strong relationships with the partners at Healthy Beings at Home, especially the housing stabilization specialist. Next slide, please. So we also interviewed study participants, as I mentioned, to get a better understanding of their experience and feedback of our collective work. So here are a few quotes from the participants themselves. I think overall there was very high satisfaction among the Healthy Beings at Home participants, and they identified positive aspects of the program. They had strong relationships with the HFF Housing Stabilization Specialist staff, and those partners who worked on the research end as well. So next slide, please. So we heard about the benefits and challenges of rental assistance in our community, such as the housing market and wages, you know, lack of affordable units, landlord discrimination, and the mismatch between housing cost and wages in Columbus were likely the biggest external challenges to positive outcomes for our families. Next slide, please. So Amy has talked about this. I mean, these were the most significant highlights, I believe, from the birth outcomes data. And she kind of outlined all of these already, but it's a great infographic to show you some of the research highlights. So we can move on to the next slide. All right, and with that, I'm happy to answer any questions about the process evaluation. I know Amy's happy to take questions around the research study, and you know, if there are any questions at this time.
Yeah, so thank you so much. We'll take questions on the program right now, and then we'll move into policy recommendations after that. So if you have questions, please enter them into the chat box. We already have a few coming through, so I'll start with those. Amy or Priyam, I think this might be good for one of you. Can you talk more about the profiles of the women that you served? Did you talk to them at all about their family histories and background? And do you have any sense of if they lived in substandard housing as children themselves?
I don't know about the substandard housing as children. One of the things, though, that we did see, I mentioned earlier that the women had significant utility debt, but yet they had no credit. And so that would indicate that they had not leased or rented a house in their name previously, but they had utility debt. So at some time, utilities had been placed in their name, though they might not have been the leaseholder on the unit that they were living in, or the homeowner. And so that does show a trend of adults placing utilities in minors' names in order as a way to get around the barrier of utility arrearages, and so we do see that as an impact. As we look at the demographics, though, beyond the ones that we looked at, we did see a slightly lower educational attainment rate. Less of the women had high school diplomas or GEDs than you would see as the standard within the population in Columbus. And the other notable item that comes to mind is that there was a higher prevalence of severe mental illness or substance use disorder within the population, although, as I stated, these were very compliant women who were seeking treatment and who were addressing their health needs, yet those conditions still existed. So though they may not have been untreated or you know, going into a negative area in their lives, they were still present for the women. I don't know, Priyam, other demographics that come to mind for you that you would highlight?
Yeah, Amy, I think you captured it really well. You know, we went through some of the criteria that women had to qualify for to get into the study, and Amy did a really good job speaking of some of the social and economic challenges that these women faced. You know, we know that they did have prior complications in getting stable housing. Many of them came from shelter. You know, low income Medicaid eligible women, very low educational attainment, and complications when it came to getting a more stable job. And so that's where we were able to work with some of the participants and bring in workforce development training and speakers to talk about, you know, how one can obtain their GED, nursing license. And we had several participants participate in some of that external additional programming, which was really nice to see.
That's great. So thinking a little bit. Go ahead, Barb.
Can I do one more quick thing? It's just for the audience is to remember we were seeking out the women who met the profile of most likely to have poor birth outcomes. So we're very tightly focused on those who are the least likely to have a positive birth outcome. And as you can see from the control group findings, we did find the right population because that is that group. And what we know about housing instability is it probably is a long-term experience, that these are women who may not have ever had really stable housing across the entire time of their adulthood, perhaps leading back into it. And when we think about housing instability, just to put a finer point on it, it's not just that they can't afford their housing and their rents are too high, which for many women that is the case, but for many of these women, they don't have any stability, meaning they've got these multiple moves, which may include stays in emergency shelter, but are also more likely to be on someone's couches or in other places where there is a high level of instability that brings a lot of other factors like domestic violence, interpersonal violence, and other forms of trauma into it. So we are tightly focused on that population who is very much likely to have a poor birth outcome.
Following up on that, I think, you know, every time I see the data, I am struck by the high number that had a prior pregnancy that may not have resulted in a live birth or living child. And I think the participants might be resonating with that as well, as we're getting some questions on that. Have any of these studies, or did this study look into using any type of childbirth educators or doula services to help with birth outcomes?
Those are all part of what's available as a usual care to the extent it's available in the community. But our focus was on what's the impact of stabilizing the housing as that specific, the specific intervention to improve it. So I know Amy or Priyam could probably comment on the extent to which in Franklin County doula services are available, because I'm not sure how readily available that is in Franklin County in any way.
Priyam and Amy, you both mentioned that there were COVID impacts to the Healthy Beginnings at Home implementation. Would you mind talking a little bit more about what those impacts were and how that might have disrupted the study at all?
So there were the traditional impacts, so women losing their employment opportunities, but then the other significant impact was the loss of child care services. And so for this group of women, it's very difficult to maintain employment without stable child care. And so we did see that, and the work that they did with their Job Connect Life Coach, we saw that as a common barrier to securing employment. From the health standpoint, I mean, across the board, we have seen just a plummet in the numbers. We have not pulled the numbers specifically for this group yet, for the well checks and immunization, but across the board within Medicaid, we see that the numbers are very low on those who were going to child well checks in the suggested pediatric service model that we do cover on Medicaid, and immunizations were really low. It was just that, I mean, for all of us, you know, that reluctance, especially in the very beginning, to enter into a doctor's office or any type of medical treatment setting, especially in settings where it was hard to get appointments because they were not allowing people to sit in waiting rooms, and they were not allowing for some of the normal congregate setting that they may receive in like an FQHC or something like that. A lot of that changed, and so that had a direct impact on clinical services that the women and the children were receiving.
I also want to share, there was a care team that consisted of Celebrate One community health worker, CareSource case managers, as well as HFF housing stabilization specialist. And they came together to address some of the needs that the participants were identifying. So Barb spoke about the doula, or there was a question about the doula services. So we do have a great doula service that we work with at Celebrate One here locally called The Root, Restoring Our Own Through Transformation. We also would take that time to identify any other connections that needed to be made either through the community health worker or through the care team.
Great. And one last question before we move on to policy recommendations. Were any of the people in the study WIC recipients?
Yes, I believe if they were not WIC recipients, that connection was made. So yes, I would say majority, if not all of the participants were WIC recipients.
Great. We have some questions that we'll save for the end. If you continue to have questions as participants, please put them into the chat box, and otherwise we will kick it over to Barb to talk a little bit about the recommendations and overall findings.
Great, thank you. Could we have the next slide, please? So as we reached the midterm of the study, our collaborative came together and looked at what would be some emerging policy recommendations that we could begin reporting. Because as Amy and Priyam have noted, the results are appearing to be promising. And so even as we have yet to approach the end of the study, we felt that there were some significant findings in terms of policy recommendations that could be made. So we've got two core policy recommendations. And the first is that we believe that it is important to test this model, the model of rental assistance with housing stabilization services, as we've defined for HBH, in other communities and at a greater scale, in allowing us to really test the impacts on maternal birth and child health outcomes. We believe that it's really important to continue to apply a racial equity lens to really understand and reverse the disparities associated with race and ethnicity. So continue to focus on the population who is most at risk. And to be disciplined as we do the replication. So we don't want to throw the kitchen sink, so to speak, randomly at participants, but instead really have a disciplined research study that uses the model of rental assistance with housing stabilization services. And as Amy had described, we followed some evidence-based practices related to family critical time intervention, housing first, other practices that we could specifically document as the model. We believe it would be important to scale this in Columbus because we have the team and collaboration in place to do this, but we also believe other communities in Ohio and across the country would be really beneficial, including a large nationally funded multi-site study across the United States so that we can make the policy argument and case for improved federal policy to invest in the type of practices that improve maternal, child, and birth outcomes. So that's our big objective, and we're as a collaborative pursuing how we can do that, but looking for partners in this work. Next slide. Our second policy recommendation is that we believe that based on the previous research that has been done about the correlations between housing instability and poor outcomes, and then this emerging research that's in Boston as well as here, that providing rental assistance and housing intervention is a promising practice at this point, and that communities could be adapting these practices to the work that is underway. Right now, a lot of the work that's focused is on medical interventions or improving other things that trend with this, the safe sleep, which is really important work that communities should continue to do. But in addition to that, we think there is the possibility for communities to improve the housing instability of women who are at risk of this. And so providing rental and utility assistance that helps to bridge the gap between the household income and the housing costs, being cognizant of the challenges that pregnant women face with having stable income during the latter part of their pregnancies as well as postpartum, providing services that help the women negotiate with the landlords, with the rental market and rearages, that those housing supports are used in a disciplined way. As Amy said, it's really important that we apply what is known in this space and we don't have to make stuff up. We've got some evidence-based practices that could be used. And then finally, this importance of having safe quality rental housing. So even though we had rental assistance available, it took us far longer to place women into apartments in neighborhoods of their choice because of the shortages in the actual market. So we encourage all jurisdictions, the state of Ohio and nationally, to continue to build the supply of safe quality rental housing so that households who have these very low incomes are able to access that. And equally important is reducing those admission barriers. There were far too many landlords who excluded these women from the quality units that were subsidized and available in the community because they did have these prior histories of eviction, prior engagement with the criminal justice system. And we know in both of those, there are systemic racism comes into play in that Black women are far more likely to be evicted, and that Black men are more likely to have interaction with the criminal justice system. And women who have interaction with the criminal justice system are more likely to become homeless upon exit and release from incarceration. So there are these racial equities that appear in these other justice systems that act unjustly. And so being aware that we need a rental market that is open to people who need a second chance and need access to safe housing. So those are our two core policy recommendations. We hope these can be embraced across the state of Ohio, but also nationally. And we're continuing that conversation with all who want to join with us. And next slide.
Great. So we'll open it up for policy and sort of broader recommendation-based questions. One of the first ones that we've received is, so you all mentioned that there are a number of barriers to actually getting these women into rental units, in part because of negative or absent credit scores, prior evictions, and arrearages. What were the practices that you all engaged in, or what did you do in order to help landlords take families with poor credit and prior evictions? Amy, I will shoot that over to you first.
Yes, so there was specific outreach that was done for landlords to talk to them about the program, why the program, and even the mayor was really talking to the landlords and advocating that this wasn't just, hey, can you look at this, but this is a part of a greater collective impact initiative within the community. And so there was a lot of recruitment on that side to talk to landlords. However, I mean, the truth is it still wasn't enough. As Barb said, we just still did not have enough units, and especially as the women looked to go to perhaps some more of the suburban areas or looked towards the outskirts, it was much more difficult to find high quality units of landlords that were willing to work with the program. And so I do think that that is an area that can be looked at and that can be built upon from a policy perspective. I don't know if we can change the mind of every landlord. I don't know if we can reverse that bias that so many of them have. But one of the things, you know, how do you help reduce those utility arrearages? How, you know, there are ways to resolve criminal backgrounds and to go through process with volunteer lawyers programs to reduce those incidents. But oftentimes evictions remain on your record long beyond 7 years, and you could be looking back 20 years in evictions. And so how can we also think about some of these barriers differently so that a person having 3 evictions when they're 21 years old doesn't continue to impact them when they're 41 years old?
One of the other barriers that we saw were that landlords in Ohio can discriminate on the basis of income. And so many landlords are unwilling to take a rental assistance, and they have strict income ratios to rent, and those exclude many people. And because of the racial disparities, it in fact does have a disparate impact on Black Ohioans as well. Some great news recently is the city of Bexley is moving forward with prohibiting source of income discrimination. If that would happen statewide, that would be a huge impact if we could do that, because some landlords just say no just because the woman can't produce the level of income that they would like to see in that. So I think that's another important policy decision that would be great to see in other cities or even on a statewide basis.
Great. This question is about sustainability of the program and what the women moved on to after. So when the women began the step down portion of the rental program, what kind of jobs were they acquiring to pay the difference? And did they have an okay time finding those jobs? So Priyam, do you want to start with that one?
Sure. So I think it really ranged in terms of healthcare services. You know, lots of, I would say, hourly wage jobs were pursued. We had a couple of participants pursue their community health worker certification during their time with us, and that's really exciting. Just more interest in the healthcare field. We had an individual pursue, I believe it was to be a massage therapist. And so we were able to give some support for from certain trainings and workforce development programs for those individuals to pursue those programs. That's great.
Amy or Barb, did you have anything you wanted to add on to that?
I just wanted to remind folks, we're still in the midst of the study, so we don't have the results from the step down. And just as step down started is when the coronavirus hit. And so we had many women who were employed lose their employment, either because they lost their childcare and couldn't go to work, or because their employer actually shut down. And so we are expecting that the women who had the interim subsidy are going to continue to struggle much longer. And we've put efforts in place to try to stabilize them for a longer period of time than we had originally intended. The women who will be the most stable are those women who were able to access the long-term ongoing subsidies. And I would say, without a doubt, we wish that all of our women had been able to have that long-term subsidy, because 21 months of assistance is not enough to make up for the lack of affordable units in our market, as well as the low wages and the irregular hours that women with low education are actually struggling with. So it will continue to be a challenge until we address the larger structural issues related to both the jobs that are available and the housing supply and the cost of that housing.
Yeah, Barb, that's a great reminder that, you know, the world that we lived in was unequal before COVID, and COVID has just exacerbated a lot of that inequality. You know, we're seeing women dropping out of the labor force at crazy rates, and the recovery has been very K-shaped. So we can probably, I would assume that all of you would agree, these are going to provide a lot of mounting challenges to the remainder of the program and those who are enrolled. One participant asked, what kind of properties were selected for participants, and was a home evaluation done for environment and safety prior to and after occupancy? I think, Amy, I'll take this to you.
So the units, as I said, we did do outreach with landlords. Columbus Metropolitan Housing Authority was a great partner in this, and all of the units were assessed with HQS, the basic housing quality standards assessment that that CMHA does for rental units, and so they had that level. Many of the units were tax credit projects that were coming online. That was part of how we were able to line up the women, especially into the subsidized units. So many of those were brand new rehabs or construction that had just occurred. So some of the environmental concerns were alleviated by the standards that OHHA has in place through the LIHTC program of, you know, green and healthy housing standards. We don't know, though, for the women in the control group, like some of them we do know found housing, and we do know that they were stable in their circumstances, but we don't necessarily know what the quality of that housing was or what level of health and safety were being established in those control units. So that's definitely an area that is kind of a blind spot within the study, except for women's self-identification of the unit.
Yes, and I'll also add, you know, there's been significant, great political will for this program that Barb and Amy mentioned. So our mayor actually brought together a group of developers to talk about the study, to emphasize the need of housing for our participants. And through that effort, there was great donations given towards the program, but also units that were identified. I think the challenge we found was that many of the units that were offered were market rate or above, and just something that our participants couldn't afford.
This question also sort of piggybacks onto that one. And, you know, at OHHA, we think a lot about the linkage between affordable housing and quality housing. And especially in very hot markets, sometimes when you have a house that is affordable, it may provide other health impediments or problems to the family that is living in there. So one participant wanted to know, were the people in the study tested for elevated blood levels, and were there any concerns about lead poisoning as part of the housing? Amy, I think I'll start with you, and then Priyam and Barb, if you want to jump in.
Yeah, that is one element because of the timing of the study. And the recommendations at the pediatric level of when children are tested for lead exposure or lead poisoning, we won't see that until actually between the kids' first birthday and second birthday. And so we do plan to continue to see what trends and health outcomes occur with the women outside of the study, but we would not know that yet. Specifically about were they tested, were the children tested, and did they have heightened levels? The other element that was somewhat outside the study, but that we are looking at, is that so many of the women did have other children within the home, and we're looking at the health outcomes of those other children, and if that changed over time. So we will look at traditional screening and prevention recommendations to see if those other children had lead exposure testing, and or if they were receiving any treatment for lead-based poisoning that we can see within their clinical data.
Priyam or Barb, did you have anything you wanted to add to that? If not, we have sort of a large macro question. So Healthy Beginnings at Home it's a large collaboration. There are public, private actors within it, and it was a really massive, and it's an amazing process to watch. For other localities that are thinking about implementing something similar, what are the key organizations or agencies that need to be a part of that process? And Priya, maybe I'll start with you and then switch to Barb and Amy.
Sure. So I'll certainly let Barb speak to this. She's very modest in her intro, but she was the brains behind this proposal. And so she's really brought a wealth of research experts, but also policy and practice experts to the table to make this program really successful. And so I would certainly stress or emphasize a backbone or organization. You know, Celebrate One served in that capacity for help and is currently serving in that capacity for Healthy Beings at Home to help organize and coordinate multi-sector partners to get the work done. I think, you know, naturally when you have cross collaboration, there's just a lot of moving parts and pieces. So a strong backbone agency would really prove to be effective. I would also stress clearly housing experts and health experts. We were very blessed to have Homeless Families Foundation here locally who do great work in the space of affordable housing and case management. And due to their strengths and their already occurring effective programming in this space, I think that was really valuable and proved to be very valuable for our participants, especially as you heard from their various quotes and feedback. And then truly an MCO that's, you know, dedicated to the work of social determinants of health. I think we've seen CareSource as one of the leading MCOs in our community to really take leadership in the issue of housing. And I will also do a quick plug for CareSource for helping us with a transportation study for our Smart Columbus project. So really grateful to them.
All great points, Priam. If I were starting this in another community, the places that I would definitely look is, one is you do need someone to be your housing partner who has connection to the housing market and can manage the rental assistance. And there's a housing authority in every community. So reach out to them and get them involved because they have the skills and the processes in place to manage it. I think a second is, as Priam said, the Housing Stabilization Agency. Again, they in our community are one of the premier organizations addressing family homelessness, but every community in Ohio also has some other organization that's addressing family homelessness and can bring that expertise of how you support the families to access the housing market and work with the landlords and really navigate that. So I think that's a second key piece. And then the third key partner is has to be the healthcare system in some way. And we were fortunate to work with CareSource. You all have managed care organizations in your community, reach out to them. You also may have federally qualified health centers that potentially could be partners or hospital systems, but look to those pieces. And then I think the next area is you need to be able to identify the women who are at risk. And we were fortunate to be able to do that because of the work of Celebrate One. As Priam said, they did serve as our backbone organization, but they also knew where the women lived, how to find them, how to market what we were trying to do to them. They mobilized their partners to support it. And they're able to more quickly kind of get in contact with them, whereas at the CareSource level, they're finding out about pregnancies through the claims and later kind of in the process. Whereas I think if you've got organizations that are on the ground and can identify the women who are most at risk, that's what you're going to need to do. And the final piece is you really do need a research partner. We ended up with 3 amazing research partners, and they could use the data that was collected through all of the partners, but also to analyze the claims data and those pieces, which I think are the final piece that bring to it. And then the other piece is getting agreement across it, having a way to build the bridges. We all talk in very different languages about this, and we have different perspectives, and there was a lot of shifting because we kind of in our head would say, well, we believe that housing is healthcare, but we had so many conversations about, well, what does that actually mean, and how do we stay true to kind of what our focus is in this? And I think in that space, it's also looking to the interventions that we know that we've been trying to do with pregnant women to improve their outcomes, but also thinking about, well, maybe those are outcomes that work really great for women who are stably housed, but maybe those interventions have no meaningful impact on a woman who is homeless. So thinking about a home visiting program, when you're homeless and bouncing from home to home, we can't just keep saying, well, we want you to take home visiting because that's going to work, but it doesn't have any connection to the fact that they're homeless or really housing unstable. So I think it caused all of us to be willing to kind of put aside our biases, come together and say, well, how do we focus on getting women into the most stable situation so they can take advantage of the resources that are available in the community at a timing that works for their lives. So it's been a really amazing collaboration, and unfortunately it is complicated and complex, but anytime I think about it, I think about the women whose lives are in the middle of it, where they don't have access to transportation, they don't have a stable place to live, they've got 2 other kids in the household, and prenatal vitamins are kind of the least important thing in their lives. And you just kind of go down that list of all the challenges they face. So what we do is in no way as complicated as what those women face trying to get through every day with all the challenges that we've put in their way and barriers to them having stability for themselves and their family.
I echo everything they said, and the only thing I would add is the funding part is not easy to solve. And so you really have to have everyone coming to the table willing to solve the funding piece. A lot of people want to look to managed care and say, hey, can you guys take this? The truth is we can pay 29 days in NICU, which is about $80,000. But currently we can't pay rent for a woman at $700 a month. So as we think about that, that is a barrier, and so we have to think of ways so we can continue to prove out this connection, so we can continue to build the research and the evidence base, so that we can show that this has a direct connection and that financially it makes sense and that there is a business case there. So that we can get to the next step. So having people who are willing to, think hard and get out the pencils and do the, numbers on the financing part is critical to the replication. So as you bring partners to the table, that has to be something that they're willing to bite into.
Thanks. And Amy, what a beautiful natural segue to the last question that I think we have time for. And I just want to underscore how impressive and important this study is. As you said earlier, we have a lot of data that suggests that not having a home leads to negative outcomes, but before this, we really didn't know that much about what having a home did for infant mortality. So one question is, aside from the small sample size, which is a limitation, what do you think are the key limitations of this study that should be addressed if there is another replication or a broader study that is done in the future? And Amy, I'll let you start and then route it to the rest of the team.
One part is funding, right? And being able to crack that code is very difficult, but it's not impossible. We were able to do it here. Obviously, scale would be nice if we had the ability to do it in 3 cities in the state of Ohio, or had some uniformity in the way we could fund this either locally or nationally. The other one I would say is data. Data is extremely important. It was great that all the women were in CareSource, but even just in the negotiating of a health information level data use agreement between a health system in Nationwide Children's Hospital and a health payer in CareSource was extremely difficult. That needs a little smoothing out as we try to exchange health information, and the acknowledgement that in most communities, Ohio is actually pretty streamlined in the fact that we only have 5 MCOs that women could choose from and 5 different groups that they could be a part of. In some states, if you were to talk about like in New York, you could be talking about 27 different MCOs that they could be choosing from. And so nationally, there's a conversation there too of like how you coordinate all that data, and to build the evidence, how do you make that as easy as possible? From our standpoint, that those are 2 limitations. And then just being able to reach the women at the right amount of time. Most women aren't finding out they're pregnant from a doctor's confirmation until they're 10 to 12 weeks pregnant. 27 weeks is the beginning of the third trimester. How do you get women into housing in that really short window is hard, but really critical to the research.
I think Amy, I want to agree. The data was really clunky in our process, which is why we ended up with 3 different evaluations. And so having the administrative data that we collected on the housing side be able to be matched with the health data is a barrier to truly, I think, understanding kind of a number of factors. The other piece in the data is being able to track the intervention a little more tightly, and understanding what services people accessed or didn't access, understand why they accessed the services that they did. We've had a lot of questions from people wanting us to be able to do that. And so having a better way to manage the data across all the different components, I think is really key. The largest issue, though, is going to be the housing market. Although it's expensive to do it in Columbus, the cost is driven largely by the rental assistance. And Columbus is still a reasonably priced market compared to some other places like Austin or Boston or Seattle. So in the high cost markets, it's unfathomable as to how we could do a national study because the cost of housing is so extreme and the affordable housing is so short in it. So I think that's the other limitation of it, is whether we can do it in high cost markets or could we do it in more mid-sized markets like we are in Columbus, and show that even in markets that housing is reasonably affordable compared to a New York City, it still is unaffordable and has negative impacts.
Great. I want to thank you all for your time today. This was really informative. Again, thank you, Amy, Barb, and Priyam for your time. For participants, please stick around and take this survey that will pop up to provide feedback. And thank you again to our sponsors and for the CoHio staff for making this possible. Hope everybody has a great day. Thanks.
Thanks, Katie.
Thank you, Katie.
Thank you, Katie.